It's my honor to invite Professor Jayant Vaidya. He needs no introduction. He is Professor of Surgery and Oncology, possibly technology as well.
Sorry, it's technology. I might record this copy.
A few with technology there. His name is almost synonymous with intraoperative radiotherapy. He's quite innovative and is involved in a lot of policy making in breast cancer treatment and therapy. So over to Jayant, and we are quite eager to listen to you. Your recent article in BMJ has stirred the entire community, and we are quite looking forward to listening to you. Jayant.
Rishikesh, Shankar, thank you very much for inviting me to address this fantastic forum. And it was very heartening that I was not isolated when people started messaging me during the slightly to Mike.
Towards Mike, yeah.
During the Manchester meeting, 2 days after the paper was published, where things were being said about me, I heard. So, neoadjuvant chemotherapy is preoperative chemotherapy. Meant, I was told by Professor Neil Mitra when I was doing my residency in Tata Hospital, to firstly, we could do it to reduce the size of the tumor to make an inoperable tumor operable. Also, to reduce the size with an aim to convert a mastectomy to a lumpectomy. We could also assess in vivo tumor sensitivity to a particular chemotherapy drug and give a clue to the prognosis. If it responds, then the patient must be doing well. It could change treatment if the treatment is not working. I have rarely seen that happen. And to approve or reject new drugs. And importantly, what is it that kills a breast cancer patient? It is distant disease. So why delay systemic chemotherapy? That is what is curing the patient. So start early. Don't delay it by 4 weeks or 5 weeks. Don't wait for surgery. So that was the reason why we started doing it. Now I believe that is probably the only real reason why we can do it today, given the evidence. So I'm going to try and convince you. So in 1998 to 1996, I was in Tata Memorial Hospital, as we are alumni here now. So that time, neoadjuvant therapy was a modern concept. The trials, which were published in the ABCTCG, were patients who were recruited between 1983 and 2001. And when I came to Royal Marsden in 1996, we started using, I saw the dramatic effects of neoadjuvant chemotherapy with Trevor Pauls and Professor Ian Smith, how anthracyclines gave fantastic results, and we toyed quite some time to not have surgery at all until many patients started coming back with large recurrences. My first warning came when I saw this paper in 2005, a meta-analysis published in Journal of National Cancer Institute, which showed that it did not improve survival. All the possible benefit that you might have by starting chemotherapy 1.5 to 2 months early didn't have an effect. No improvement in survival, but there was a statistically significant worsening of local control. So then I started wondering, is this really a good idea? Then in 2012, the Cochrane Review said exactly the same answer. The final push came more recently. It's when pertuzumab was being used. And pertuzumab is anti-HER2 therapy, which was found to improve the pathological complete response rate from 22% to 39%. Naturally, it was logical to believe that this must be better for the patient. And therefore, medical oncologists with very good intentions felt we should give it to everybody, whoever for whom it is suitable. And there was no license. There was no license for it to be given as adjuvant setting because the Affinity randomized clinical trial was still recruiting. So how do you get pertuzumab into a patient? So most MDTs I was going to said, oh well, this patient is HER2 positive, let's give a pertuzumab neoadjuvant because it is licensed for doing that because of these results. So patients started getting more and more pertuzumab for patients who are 1 centimeter cancers easily operable by breast conserving surgery. So Affinity trial at that time was not reported, so every HER2 positive was given this argument. She'll need chemo anyway, she'll need anti-HER2 therapy anyway, why not give it in the beginning? And then this paper was published. This paper was published, which was a pooled analysis, and this was commissioned, I believe, by FDA. And so the first author is from FDA. Now what was found? I mean, the whole point was that if you improve the rate of increase in pathological response rate, so instead of increasing from 5% improvement of 10%, doubles it, it would improve survival in a similar manner. And this paper showed that the hazard ratio, which is on the x-axis of improvement in pathological complete response rate, has no relationship with improvement in event-free or overall survival. So what we are seeing in a patient, the whole hypothesis is based on the idea that a tumor in the breast is representative of tumor in the rest of the body. And that is the logic of all of neoadjuvant chemotherapy regimes, and this seems to go against that. This seems to disprove it. Affinity trial results were published in ASCO 2017. We were all waiting for it really very eagerly, and I heard nothing after that. Everybody just kept quiet. What was published? This was in New England Journal of Medicine. I was quite shocked. This is what was published on the left-hand side in the main paper. Can you see these lines? Do you see any difference in these lines at all? And that is, this is what it was. In this difference of maybe hardly 1%, p-value of 0.05, and this was the headline of the paper. And what is the outcome? Invasive disease-free survival. Had anybody heard of invasive disease-free survival before? I'd heard of disease-free survival, overall survival, but invasive disease-free survival, I said, well, okay. Then I looked in the paper, and then on the page number 31 of the supplementary appendix, I found overall survival outcome. And it said it's not at mature enough, but you can see there are nearly 3,500 patients at 42 months follow-up. How much more follow-up do you need to separate these lines? And you can see the stark contrast between the pathological response rate improvement and no difference in overall survival. And this is not just limited to pertuzumab. It happens in NeoAlto study, in lapatinib, it happens in bevacizumab. You feel a big difference from 28% to 39% improvement in pathological complete response in neoadjuvant setting, no difference in overall survival. So then we wrote this paper in August 2017. I've been writing it for some time. We submitted it to the BMJ, and it got quite a good peer review and robust, and it was published. And these are the key messages, is that neoadjuvant chemotherapy is being increasingly used despite higher rates of local recurrence. And that was known by the time we wrote this paper. And mainly because we are seeing dramatic responses. It was logical to do it. I'm not saying it is done it's done with all good intentions. So there was increased response, does not lead to increased survival. So it challenges the whole paradigm of window of opportunity studies. Window of opportunity study, it was done with a beautiful idea. So you have a cancer, like antibiotic resistance, you can see how it responds to a particular treatment. If it responds better, the drug will be better. That was the whole idea of I-SPY 2 trials. But it doesn't seem to be the case in all cases. It may probably work in some cases, but that relationship is absolutely haphazard. It's not linear. It may work, but not always. So we cannot use that as a paradigm. So we must acknowledge now, today, neoadjuvant chemotherapy may not be beneficial to patients, and we should really strongly consider this evidence and consider whether we should stop using it as much. And then after we had submitted the paper, the meta-analysis from EBC-TCG came out, and this is what it showed, showing that local recurrence, even if surgery is commonly used, is increased by a small amount. If it's not used, not commonly used, it's increased by a large proportion. And if you reduce your extent of surgery from mastectomy to breast conserving surgery, you find that the recurrence rate is much higher. Mastectomy to BCS, much higher recurrence rate. If BCS to mastectomy, the recurrence rate is lower. Now, people have criticized EBC-TCG meta-analysis, saying that they are old studies, and we have better drugs which improve the outcomes. But taxanes were already included in the meta-analysis. The newer drugs are mainly HER2, anti-HER2 drugs. Now, this is a meta-analysis of anti-HER2 drugs. It doesn't improve local recurrence. So EBC-TCG concluded that it increases probability of breast conserving surgery by 15%. That was in the meta-analysis. It increases overall risk of local recurrence by about 5.5%. And when 1% increase of risk was found in the Target A trial, people thought it was going to kill people. That is what was said in the appeal against the NICE decision. 1% increase in local recurrence because of IORT was being told to NICE as killing people in UK. So don't let it be approved. Now NICE threw out the appeal. So here is 5.5% increase in local recurrence, and it's 13% if surgery is less commonly used. It has no effect on breast cancer mortality, but with 4,500 patients, they have said we cannot detect about 1% increase in mortality. Now that is in a meta-analysis in randomized trials. Now what is the current data? This analysis was published just recently in 2015 from National Cancer Database of 59,000 people, 16% of whom had neoadjuvant chemotherapy in America. So this proportion rose from 14% to 20% from 2006 to 2011. And what did they find? In real life, it improved breast conservation by only 10%, just 10%. Majority still have a mastectomy. You can see from this graph how majority people have a mastectomy. Very few people have breast conservation. So this increase from blue to red is only 10%. And they were giving neoadjuvant chemotherapy for patients less than 3 centimeters in size, and in those, there was reversal. From breast conservation, it went to mastectomies. So there's a price to pay here. This reversal is one price, and second price is increase in local recurrence rate. So patients need to be told that you're going to have neoadjuvant chemotherapy, there is no survival benefit, you will have increased local recurrence. And then if the patient accepted, that is fine, because there is increased risk of 10% increase in breast conservation. And less than 1% mortality difference cannot be confirmed. So this is the slide I showed by mistake earlier. So there is no increase in breast conserving rate in this meta-analysis by use of anti-HER2 therapy as neoadjuvant chemotherapy. So breast conservation rate doesn't improve if you add dual or single. This is trastuzumab, not dual. So people have wondered why I have said in the paper that surgery is technically difficult after neoadjuvant chemotherapy, and they were questioning whether I do operate or not. Well, I do operate every week, and it is not technical difficulty in surgery, it's conceptually difficult surgery. And it was difficult actually to find a female surgeon's photograph when I was trying to find one, but I did. The point is, the clip is in the center of the tumor, and surgeons are told, remove the tissue around the clip. Even MRI can't estimate the exact extent. Why should the residual cancer cells gather around the clip? So if this is the cancer in the breast, so you give neoadjuvant chemotherapy, you put a clip in, you can see the clip somewhere there, and you give neoadjuvant chemotherapy, cancer goes away. But there are some cancer cells left behind, and then you remove a cancer. Margins are clear. What about the remaining cells? That's probably the reason of local recurrence. But if only the clip was a magic clip, you put a clip in, and then the cancer goes away, and because it's a magic clip, all of them go and gather around it. So that's very nice. So, but we don't have this. And one of them will go back anyway. So we don't have this yet. Then it would work. But so how can you do more breast conserving surgery when it's the same area of tissue? What about the patient? My registrar's mother had breast cancer and he was given neoadjuvant chemotherapy. And he told me how horrible it was for every night when she lied down, she felt the cancer in the breast for 6 months. She didn't like it. So this small study has found that 41% of patients had depression after treatment in the HET score. There's not a very randomized study, but it is quite high. And people keep saying, somebody said 50 to 80% get response rate. Now I asked this question to the authors of Neosphere study, and these are the numbers that they gave me because they are not there in the paper. What are the complete response rate, that is breast and axilla, in a patient receiving dual anti-HER2 therapy with the best treatment available today? And that is the one in ER positive patients. So 78% patients of ER positive, HER2 positive patients will have residual disease at the end of 5 months. Patient living with the cancer. Whereas here, if he best possible, ER negative, HER2 positive, what is the answer? 46%. 46% patients, half the patients will have residual cancer left behind by the time you do the operation. And what happens when we do an operation? Now most of us are surgeons. We do an operation, at the end of it, it's 100% response rate, isn't it? Even if you're margin positive, you can go back and take it out. So within a day, you have 100% response rate. Now what would the patient prefer? Now there are models of disease, there are mechanistic methods of may not be correct, but at present, we do believe that taking the cancer out of the body is a good idea. And unless this is better, we can't say that this is what we should do. So is it valid to wait to give neoadjuvant chemotherapy just because we are waiting for BRCA gene testing? Again, we need to warn the patient. Is it valid to wait just because there is no time in the operation list? Because there is no time for plastic surgeon to do the reconstruction? I don't think so. Is the additional extra surgery for sentinel node biopsy justifiable? The whole argument about when to do with the axilla will disappear if you don't use neoadjuvant. You need it. Why do additional MRIs? So then we keep seeing MRI images. Well, you do an operation, at the end of it, there is no cancer left. Well, that's what happens. We look after margins very carefully. What radiotherapy does is a different thing altogether. Fertility preservation is one reason why we should operate first, and then the fertility preservation can happen. Now, this is a paper I came across after we published the paper, is that this was a paper in Science Translational Research, Medicine, in which they actually tested patients receiving neoadjuvant chemotherapy for assessment of what increase in this cell dissemination. So what they found is it evokes a host tumor repair response. Bone marrow derived cells infiltrate the primary tumor and create what they call a TMEM, that is tumor microenvironment of metastases induced mediated mechanism of spread of cancer cells. So this suggests, and they showed there's increase in cancer cell dissemination when there is neoadjuvant compared with no neoadjuvant therapy. Okay. So 2 minutes more. So in 2 minutes, I want to tell you about intraoperative radiotherapy. This happened in Bombay. So the patients used to get a mastectomy because they couldn't travel for the radiotherapy. Based on laboratory work, I suggested that only the tumor cells around the cancer need to be treated. The other cells may not need treatment. So in collaboration with industry, we devised a method to give radiotherapy only around the tumor. So, and tested this in a randomized clinical trial called the Target A trial, and that is Professor Baum. The trial has now been published twice, and now there are about 20,000 patients who have been treated, and these are the user group meetings. And this trial found, run in about 1.1 million fields. And what did we find? This is published in the Lancet, and conclusions in the front page, and answering the question to a patient, what is my chance of being alive with these two treatments? It is 93.1% versus 92.5% with being alive without local recurrence. There were fewer deaths, and this is one point I want to make. There were fewer deaths with intraoperative radiotherapy, and this is plausible because we know that the increase in cardiac deaths starts occurring in the first 5 years, as was seen in Sarah Darby's paper from Oxford. And we proved in a meta-analysis where that targeted radiotherapy actually has better survival by just 1 or 2%, but in patients whom overall survival is 95%, that 1 or 2% matters. Wound fluid collected during surgery stimulates cancer cells. And if you give IORT, this stimulation is reduced. And you can see how they're moving very fast there and not moving very fast when they have IORT because of various cytokines. And based on this, we suggest that it may have an effect which is beyond the wound. And this paper, in which we gave IORT after patient is having breast conserving surgery with neoadjuvant chemotherapy, this was study done in Germany, 116 patients, where we found that there seems to be, in a retrospective, non-randomized manner, there seems to be at least as good local recurrence, probably better survival because of what we call effect away from the tumor. So that's the aim for the intraoperative radiotherapy. The paper in the BMJ had about 7,000 views. Podcast has 9,000 views. We've got many good people tweeting about it. So it has started a conversation, and these are the key messages. Thank you.
Thanks, Jan. We'll take questions at the end. Is that all right?
Yes, sure.